All right. Welcome to this Spark Session interview as part of our inaugural Maternal Health Innovation Symposium. My name is Allison George. I'm with the training team at the Maternal Health Learning and Innovation Center, and I'm here today with Retta Gill from the Rio Health and Tucson Medical Center to discuss your midwifery program. Welcome, and please tell us more.
Well, thank you so much for taking the time to talk about what we're doing down here in Tucson, Arizona. We really feel like we have created a program that can change the template of maternal child health care. And so I'm excited to tell you about what it is and how to go about doing it where you are.
So what is happening in El Rio?
So El Rio Health is a federally qualified health center. 2020 is our 50th year of existence, and midwives have been part of the health center since 1977. So El Rio has had a strong longevity and commitment to providing the midwifery model of care. We have a diverse population that we serve, and we have several projects with our partner community hospital, which is Tucson Medical Center. It's a nonprofit. And so we have engaged with them on primary care and access to outpatient services in a collaborative way. But we've also now partnered in order to provide the birth center model of midwifery care within the hospital. And so that's what I'm here to talk about.
And how's that different from a normal birth experience? If I were in another community, how would your community's setup differ?
Well, the birth center model of care was, and birth centers in and of themselves were established more than 30 years ago nationally to provide a physical space for the delivery of midwifery care. And that is distinguished from obstetrical care because the model is quite different. If you are seeing an obstetrician, then pregnancy and birth are modeled as illnesses or problems that would be better taken care of with medicine or technology. And the midwifery model of care acknowledges that while some pregnancies are complicated and are made safer with technology, the majority of pregnancies are not. And so the midwifery model of care is, what can we do to keep normal, healthy pregnant women normal and healthy from the onset of prenatal care until after the baby is born? And so the birth center movement was really started as, well, it was very difficult to provide midwifery care within an obstetrical space. And so birth centers were established as a place for families to go to have more bonding time or less separation or not routine episiotomy or lower rates of cesarean section. And the relationship between midwives and obstetricians has become more collaborative over the decades. And the evidence about the care that we provide has become more integrated into the hospital or into the healthcare system in general. So great example is the golden hour. We now, no matter who the parents are and what the circumstances of their pregnancy and birth are, we have institutionalized the golden hour as a very important part of the newborn's transition from being in the womb to outside. So 20 years ago, you would have to have a home birth or perhaps be with a midwife in a birth center to birth your baby and then have that uninterrupted skin-to-skin time. But now it's part of how we deliver care in general in the hospital. And so why have a birth center in the hospital? Well, it takes it to the next level. So we really know that when you have lots of support and mechanisms and systems for physiologic birth, meaning you don't have routine interventions, you don't have women on fetal monitors, you don't have women automatically hooked up to intravenous lines. You don't restrict their movement. All of those things enhance normal spontaneous birth. And so if you create a system where you can make it the usual and routine part of care, then what are you going to have? You're going to have healthier outcomes. The number that everybody watches is, what is the cesarean section rate? Well, how can we keep that low? We know that women who birth spontaneously and vaginally have less risk of all kinds of complications in the current birth, the current pregnancy, and any future that they have. And so we really are invested in keeping that C-section rate very low. So birth centers across the United States, but now, the midwifery model of care, and particularly the birth center model of care, no matter where you are, you can expect to have a C-section rate well south of 10%. And so, nationally, we live in a place where we accept that 1 in 3 births needs to be surgical. And that is not leading to healthier mothers or healthier babies. In fact, we're in a crisis where we have increasing maternal mortality, and some of that may be due to the high rates of surgical birth, and then also things that decrease access to models of care that keep you low risk and healthy from the start. So we were lucky enough to participate in the Strong Start research, which was a several-year study looking at Medicaid recipients in a usual model of prenatal care and birth, a midwifery-led or a maternity home, and then the birth center. And of course, the birth center was shown to decrease cost, increase the number of unscheduled births, decrease the number of cesarean sections, increase the number of women who were exclusively breastfeeding at 6 weeks postpartum, many more exciting outcomes. So our program really is meant to be a model to demonstrate, well, if we want to change how we deliver healthcare, we have more than 300 freestanding birth centers in the United States, but 99% of women go to a hospital to give birth. And so what's going to really change the care delivery is changing what is happening inside hospitals. And so what we have established, we established it in July of 2019, is what is called an alongside midwifery unit. And so women come to our freestanding, our federally qualified health center for their prenatal care, and we discuss their birth options. And when women are healthy and low risk and motivated to have an unmedicated birth, then we really prepare them for the birth center model, which can include going home on the day that you give birth with outpatient and home visiting nursing services, instead of staying overnight, 1 or 2 nights in the hospital. So we have now about 40% of our mothers who are planning the birth center model, which is very exciting. We serve over 1,200 pregnant women every year in our service, so we're quite large. And so having that number of women prepared and interested in the birth center model doesn't mean that everybody remains eligible, because the birth center model is really designed for women who have full-term pregnancies, spontaneous labor, uncomplicated, so no high blood pressure or diabetes and the like. And so when you have all of those things, which most women are, full term, they have 1 baby, the baby's head down, and the labor's starting on its own, even if mothers choose to leave the birth center and decide to get pain medication during labor, we still have a 95% vaginal birth rate of women who are choosing the birth center. So that is truly, truly exciting. So there's some magic in all of the preparation and getting women to the right level of care, not overusing technology, but then also not putting women who have risk factors in a low-tech version of care. So really right-sizing the care so that women are at the level that they truly need, and that is how you get healthy outcomes. So our alongside Maternity Center, or it's alongside Midwifery Center now, that's the official term, is accredited by the Commission for the Accreditation of Birth Centers. And we chose to have voluntary accreditation. Freestanding birth centers also are accredited by the Commission for the Accreditation of Birth Centers, but there's only 5 in-hospital alongside midwifery units that are accredited. And what it does is it provides a template for truly how to provide low-risk care. You need to define your eligibility criteria. You need to define what are the resources you're going to have available. You need to hone your processes for what happens when someone becomes ineligible, and you need to monitor the quality and safety of the care that you're providing. In addition, you need to monitor how the mothers and families are feeling about the care that they received. And so we voluntarily chose to be accredited, and we are. And so I would encourage anyone who is running labor and delivery or maternal child service who wants to think about how can we improve the care for healthy low-risk women. How can we do a birth center model within a hospital to truly look and seek out the accreditation? You don't have to have millions of dollars for remodeling. You don't have to have a separate facility, but you do have to have policies and processes that clearly define how patients are going to be cared for, how you're going to provide low-risk birth care, and then how you're going to monitor quality and safety. So we were very lucky that we had a template in that we had a freestanding birth center that we moved into the hospital. So we did have a template. We had policies and things that could be easily translated over to what we were doing within the hospital. But really the exciting thing, and why I would encourage listeners of this interview to explore this, is that we are providing this really important service in the place where most women are giving birth. And so we feel like women will continue in the United States to go to hospitals to give birth. And so we really need to look at how are we providing the care and how can we keep people safe and healthy.
So it sounds like you originated in the FQHC and then have helped your patients with their care in the hospital.
Mm-hmm.
Okay.
Yes, we've always had birth care and hospital-based birth care. We did for a decade also have a freestanding birth center. And we were excited to see the increase in number of women who were choosing midwifery care for their maternity care. However, we were seeing a declining number of women choosing the out-of-hospital birth program. And so really we decided to take our program where the majority of women are giving birth, and what we have seen is an increase in utilization of the program. And so we really have combined the best of both worlds. And part of it was the collaboration that our FQHC has with this community hospital. But it also was excitement on all levels. So, you know, having the midwives engaged, having the nursing leadership engaged was really a big part of the success of this program. Also, the obstetricians that work with the midwives that have known us and supported us. Additionally, what was exciting about our program is that midwives and birth centers are the primary care provider for the newborn until they're established with a pediatrician, and we had been doing that in our freestanding birth center. And we had support from the neonatology team at Tucson Medical Center to expand the scope of practice for nurse midwives. And so we now have the scope of practice to admit and discharge newborns in our program, which was a really big advancement for us in terms of midwifery care, but also in terms of being able to really be true to the birth center model of care, which is that you keep healthy people where they belong, in their homes, or, you know, utilizing systems only when it's medically necessary. So, and this is not, I will say that our program is not, we didn't invent this model of care. This is not novel. This is what happens in the developed world, where there's midwifery-led care as the standard. So in Europe, in Australia, in New Zealand, in the UK, midwives have always led the maternal child health care. Women are used to going to midwives and only see obstetricians if things are problematic in their pregnancy. And so in those places, there are midwifery-led units, and then there are obstetrical units, and sometimes the midwives will attend their patients on the obstetrical units. But in general, the majority of the lion's share of pregnant people are going to midwives unless there is a clear and compelling reason why they shouldn't. And that is precisely the opposite of what we have in the United States, where midwifery-led care is the vast minority of the maternity care that is provided here. And so you really have parts of the United States where there are very few midwives available. And we also note that in those parts of the country, sometimes the outcomes are less than in parts where there's a lot of midwives, or they're not as good. So we really feel like midwifery-led care isn't just, well, let's have someone who has, you know, sort of the same training as an OB, you know, just do all the vaginal deliveries. It's really, what is our model? What is our philosophy? How do we prepare women? And then how do we see that through? And so this is having a space within your unit to provide, or a stated policy saying, for these clients, when they're eligible, we are going to provide truly midwifery-led care, and we are going to do that in the birth center model unless there is a clear and compelling reason why we shouldn't. And so when you have that in place, then you get really very happy patients, number one. And number two, you get really healthy and exciting, really exciting. It's been exciting for Tucson Medical Center to adopt, and to adopt the model, but also to see, you know, what happens when you have low-risk healthy women stay that way, and what happens when they leave the hospital in 4 to 6 hours after giving birth. How often do problems come up? And so after a year now, and a little more, we have really been excited to see, not only demonstrate the program that we knew would work, but also to have it experientially confirmed by all of the staff participating. And so there's been tremendous momentum and excitement to increase the number of women who choose the model.
So it sounds like part of the model is identifying who are the women or pregnant people at low risk who are good candidates for midwifery care.
Yes.
Seems like another successful step is having it located in the hospital, which is where people in the United States at least are accustomed to going for their birth experiences.
Yes.
And it seems like you have a wonderful relationship between the hospital and your pre-existing FQHC already. If I were a provider at a freestanding FQHC in another part of the country and interested in this model, we're running low on time, but how could they get a hold of you for more information of this model, or what suggestions would you give them for moving in this direction?
Well, I think if you're going to start any new program, a multidisciplinary approach is critical. So we had neonatology, and we had nursing, and we had medical staff, midwifery staff, and administrative staff from both the FQHC and the hospital invested in the success of the program. But I have been excited with the number of places that have contacted us, and we've had a couple come down to Tucson to tour to just really learn about what it is that we're doing. So we are happy to do that. The way to contact me is midwife@elrio.org, and I would be happy to guide anyone who has questions about establishing this model. But also the Commission for the Accreditation of Birth Centers is another place to look at. You can go to their website and really see the template. What does it take to have an alongside midwifery unit? What are the standards and indicators, and what is the process for becoming accredited? Because it really does help you not feel like you're starting everything from scratch. It helps you identify, okay, well, what do we need to do? What are the steps? And then I truly believe that the accreditation is your commitment to saying, okay, we really want to do a true birth center model. We're going to do that within our hospital so that when you're offering that to the consumer, they can really feel comfortable that you are not going to change course without really having all those pieces in place that they will be expecting.
Well, the Spark sessions are intended to make people hungry for more information and to spark ideas. So I personally am frustrated that our time is up because I would love to know more about this. Thank you for your time and your explanation. And maybe we'll have time for a longer conversation in the future. So thank you very much today.
My pleasure. Thank you.